Another thing I found with doctors, obviously all of us have been harmed by doctors if we are in this mess or listening to my interview. So clearly we have some healthy skepticism of the medical profession. But what I've found since I was injured is my interface most of the time with the medical profession has been quite favorable. And a lot of it's based on being armed with as much information as I can. And so as somebody that was harmed by benzodiazepines, I wanted to make sure I understood anesthesia as best as I could so I could give them as much information so they could give me the safest amount of anesthesia.
Hi, I'm Dr. Josef Witt-Doerring. It is my pleasure to be joined again by Chris Page, one of our regulars on the channel. He's constantly invited back for his own personal experience with protracted withdrawal, but also ongoing recognition and leadership in the space for being someone who's great to go to for help with this issue. And so, Chris, thanks for coming back on again and sharing your thoughts with us.
Always such a pleasure. Thank you again for having me.
So, Chris, I think I'd like to ask you a little bit about managing surgeries with protracted withdrawal. Can you talk about your own experience with your prostatectomy and what it was like preparing for that and going through it?
Sure. So I think this is a big fear for a lot of people going through withdrawal is how will I interface with the medical community? How will I, if I'm vulnerable, how will I manage things as life, has a tendency to throw us things that make us have to get medical treatment. So for surgeries, and again, I think this is important to realize this is my story and my story only. This isn't my medical advice or what, this is what worked for me. Will it work for you? I hope, but it's just some general guidelines I think that are important for people to consider. The first thing, and most people know if they've had surgery, you'll go through a couple phases of interviews with anesthesiology. And so the first thing that I try to always kind of plant as the seed is what is the least amount of anesthesia that we can administer to me to successfully complete this procedure? Is it possible to get a nerve block where I'll need less general anesthesia? Is it possible just to do the twilight anesthesia for like a colonoscopy or an endoscopy? Are those possibilities? So just kind of creating dialogue with your anesthesiologist. Another thing I found with doctors, obviously all of us have been harmed by doctors if we are in this mess or listening to my interview. So clearly we have some healthy skepticism of the medical profession. But what I've found since I was injured is my interface most of the time with the medical profession has been quite favorable. And a lot of it's based on being armed with as much information as I can. And so as somebody that was harmed by benzodiazepines, I wanted to make sure I understood anesthesia as best as I could so I could give them as much information so they could give me the safest amount of anesthesia. And so the first thing that I always insist on that I have on my allergy bracelet is a benzodiazepine named Versed, Versed, that they use in a lot of anesthesia. So I tell I tell the anesthesiologist I cannot have Versed. But another thing I've learned with doctors is if you are saying you can't take a certain medicine, it's often in your best interest if you've researched enough to find a medicine that you think they can substitute if they need to. This kind of gives them then the ability to still make decisions and still treat you, but you have a lot more kind of, I would say, control over what possibly might be administered to you. So when I tell them I cannot take Versed, I will tell them, but I can take propofol or fentanyl. And I've had both of those administered to me before in surgery and not had an issue with those. And I know that opiates especially are being, more and more explored as a potential treatment for akathisia. So I think from my past history of akathisia and opiates being used surgically, I have not had an issue with that. I know other people might have a different experience, but that has been my experience. So then the other things that I found will happen in working in a surgical environment is they're going to want to explore giving you anti-nausea medicine. So for me, another thing I have very explicitly on my allergy bracelet is Reglan, Reglan, which is an antiemetic. It's an anti-nausea medicine, but has been known, unfortunately, anecdotally, to have a lot of issues, including akathisia. So it's something that I've always wanted to avoid surgically. And I've always been very clear with nurses and anesthesiologists that they can't administer that. So to solve the problem I said earlier about giving them options, I'll tell them that I can take another antiemetic, another anti-nausea medicine called Zofran, Zofran. I know some people have had issues with Zofran, but I have not had issues with Zofran. So I can give them that as an option, even though I will say to them also, you can allow me to be nauseous as long as you're not worried that I'm throwing up too much. Nausea is a very normal post-surgical experience for people as we're kind of processing the anesthesia. But I've always tried to do less is more, less medicine the better. But if they need to give me something, they can give me the Zofran. And then another thing that always comes up with surgery are antibiotics. And anybody that has heard my full story knows that one of the real precipitating events for me was taking ciprofloxacin, which is a fluoroquinolone antibiotic that gave me insomnia and agitation. So I have fluoroquinolones as a class of medicines on my bracelet that cannot be administered. I also have penicillin, which I had as a child, but also beta-lactams, which are penicillin-based, can cause issues for some people because they cross the blood-brain barrier, as does doxycycline. Also has some ability to agitate people. So that's another medicine I've asked to not be given unless it's absolutely necessary. So I tell them instead the antibiotics that my body can tolerate, and this again is by trial and error, so it doesn't mean that my body is everybody's body. This is just what worked for me. And that's Bactrim, which is a sulfa drug, and then azithromycin, which we also know as the Z-Pack. And between those two, you get a lot of positive and negative gram coverage in terms of bacteria. So I'm generally been able to have doctors use those as I've gone through surgeries. And again, because I think for all of us, we want to minimize the exposure to any potential substance that we fear could cause a setback. So for me, it's been opiates are okay for me. I've been, very specific about the antibiotics I would prefer. I've been very specific about not getting Versed. I've been very specific about which of the anti-nausea medicines. Another surgery, they wanted to give me gabapentin, which they often use for pain as a pre-surgical pain medicine, and I was able to refuse it. So I think that's another thing that people need to recognize as an important thing, is to arm yourself with the knowledge that unless something's absolutely medically necessary, you have the ability often to refuse things or to suggest alternatives. So you have some more control over your own health as you go through a scary process. I hope anyone listening to this, if you are getting ready for surgery, have a safe and comfortable and healthy experience from it. For some of us, it's a necessary evil that we would not choose to have, but we have to have. And so the best way to navigate it are some of the tips that I found that I just shared.
Yeah. And Chris, I just want to clarify something on my side. You cut out when you were talking about the anti-nausea meds. I assume you mentioned Reglan or metoclopramide as being the one
Yes.
you wanted to avoid?
Yes, yeah. That's number one on my list to be avoided for sure. That's one, unfortunately, anecdotally, we know a lot about causing issues for both non-injured and injured patients. So,
I guess thank you for that overview. I mean, where do we send the medical diploma? Because that's that's quite a lot of pharmacology that you figured out, and it's spot on. And I wanted to add my experience just with what people have and haven't tolerated antibiotic wise is, well, I guess the first thing is there's never no risk. For instance, I've heard of some people having neurotoxic reactions to drugs like cefepines and the cephalosporins like Keflex, Ceflex, which are really commonly used. I think they're pretty close to the penicillin-based antibiotics. And mostly they're tolerated just fine. I mean, there's small risks. So I've seen people do well with those. Same with even, the fluoroquinolone's definitely one to avoid. But again, that would be a less common adverse reaction, but it's one to be avoided. So when I think about antibiotics and I advise people, I look at the warnings and precautions sections on the FDA labels, and the ones that I'm particularly worried about is, the fluoroquinolones, because right there it says, severe neuropsychiatric adverse reactions right there in the warnings and precautions. And it's there for a reason, because it's common enough and dangerous enough that you should avoid it. The other one that I think people don't notice is Flagyl, which is
I was going to mention Flagyl. Yep.
Yeah. Flagyl's for anaerobes. That's, I guess it's oxygen consuming bacteria, but usually people get anaerobes, will need that for GI surgeries, things like that. And so I think about those two as being the ones that people should really, if possible, steer clear from. And everything else it's just, sure, there's some risks, but the chances are it's going to harm you are quite small from what I've seen. Yeah.
And I think the other thing that I forgot to mention that's so crucially important is, because I am taking medicine, I studied the CYP 450 metabolic pathways of all the medicines I'm taking. So I understand specifically any interactions, because again, I haven't found medicine always takes that fully into consideration, is the potential for interactions and potentiation and inhibition and different things that can cause dosage issues with any medicine you're taking. So I try to be as armed again as I can, so that if they propose any medicine, the first thing I'm doing is looking it up on my phone to see if there's a known interaction. And then second, making sure that if there is a known interaction, that I'm not being administered the medicine. Mm-hmm. So it's another just, I think, crucially important part of protecting ourselves.
Okay. So, Chris, I think that's about it for today. I'm kind of done with my questions, and I think that was a really good overview of surgery. Have we missed anything that you had that you wanted to discuss before we wrap?
I don't think so. I think, again, just arm yourself as much as you can for the knowledge that you think applies to your situation. But I hope some of the general information I've given at least helps guide that process for you.
Chris, it's been a pleasure having you on. Look forward to seeing you next time.
Such a pleasure. Thank you.